يعني I will share with you a case courtesy of Mahmoud. This patient, 54 years old, presented with knee pain and disability, and with this severe varus and joint depression and flexion deformity. Do you like to comment, Dr.
Dr. Ahmed Abdelaziz, it's a perfect case scenario because we have missed already the case of Ayman Suleiman. So perhaps we can take the view of some of the audience. If you face someone with a severe varus deformity of that degree, what further assessment would you like to see?
Thank you. This is how his knee and leg looks like. It's not just a varus at the level of the knee, it's another problem distal, far distally.
Yeah, perhaps, Dr. Ahmed Bey, we know that he's 50, how old is he? 54? 54 years old. He's got severe varus deformity with an extra-articular diaphyseal deformity of the tibia with previous surgical intervention, metal work, and perhaps we can get the view of some of the audience if you like. Can we have microphone here, please?
No. So how would you proceed? Any suggestions? Would you stage the correction of deformity extra-articular and then do the replacement, or you do it as one stage? And if the metal was a little more than this, would this affect your decision whether you go for definitely staged procedure, or you just remove the metal, correct the deformity, and proceed with the replacement? What do you think?
Someone is raising his hand. Would you like to say something? Please comment if you like.
But I think if we correct the deformity at the side of the cora, the diaphyseal, and extend the stem, maybe augmentation of plate fixation might solve the problem.
Very good, thank you. If the metal was a little more than that, would you do it one stage, or you stage it?
Two stage.
Two stages, yeah. Is there an indication for staging removal of metal and then coming back to do the replacement, whether there is deformity or not?
Professor Hirschman, do you have any suggestion?
مايك لو سمحت.
Yeah, but I think if you see such cases, you always have to rule out infection first, and if this is, that's why you probably said maybe do implant, remove the first, take some biopsies, and then come back. That's one thing you have to rule out first. I would actually correct the extra-articular deformity with a nail, and then stage the later knee arthroplasty if necessary. In some of the cases, you see that actually it's not even necessary to do a total knee because they become more happy afterwards. So, but I would correct it with a nail and then yeah, do a total knee, a stage procedure.
Back to the question of should we every metal should we remove and stage, or there's an indication if, for example, if I have an oozing wound, scar healed by secondary intention, diabetic patient, sluggish circulation or whatever.
Yeah, if there is a high likelihood for an infection, and if there was an open fracture, for example, then I would definitely stage the procedure, yeah, to be safe on this side.
Thank you very much. So we are between staging, the correction, and then replacement. And Mahmoud's choice was actually to go ahead with the this is the patient walking مسكين خالص يعني. So he elected to do the correction of the deformity and replacement at the same time, but we have to go through certain steps. The femoral preparation is like normal. On the tibial side, you can put the wires that leads the correction of the deformity and straighten the knee, and then do the intramedullary reaming and put flexible wire, and then put the rigid reamer to fine tune the corrections so that you have total contact of the osteotomy ends, and apply your fixation with the rigid reamer inside so that you wouldn't block the stem, the descent of the stem during insertion of the and this how it ended. The deformity corrected, the osteotomy fixed. The stem might be a little shorter than I would expected, but the patient is actually happy with the result, and he is. I'm not sure he still have his dressing, but he can move around, put some weight. Of course, has to be partial. You may disagree on making it at one stage, but it worked. This is another case with extra-articular deformity. This lady actually is very unfortunate. She had an amputation on the other side, above knee amputation, and she's using an artificial limb. And the same accident, she had these fractures that caused the angulation displacement, and these are the numbers of the deformity, both in the sagittal and in the coronal direction. So, Dr. Ayman, how would you proceed with the management of the case?
It's a very complex deformity because it is you have to consider the deformity on the sagittal plane as well as the coronal plane. Can we go back to the X-ray, please?
Sure.
And obviously, we have, as I said, the deformity is biplanar. It's not only in one direction, sagittal plane and the coronal plane, but because I'm not sure. Perhaps we can get the opinion again of the audience if they wish to comment on an extra articular deformity. When would you consider an osteotomy to correct the deformity, and when would you consider correcting the deformity within the cut of the knee joint? Anyone would like to comment? Dr. Adham, would you like to say something, please? Can we have a microphone? Dr. Adham الشرقاوي لو سمحت.
شكرا دكتور احمد بيه الحالات الجميله دي. In fact, what I do, just I do a line of the anatomical axis of the femur, and I look at the exit of this axis. So in this case, I think you can get away with just the line is getting a little bit lateral and a little bit posterior. If this line goes outside the boundaries of the knee, I have to do extra-articular osteotomy or so. But for this case, this line, anatomical axis, will exit a little bit lateral, a little bit posterior, and will do a primary knee like everything else.
What choice of implant would you like to use? If you are using, if you are going to make the whole correction intra-articular, what difficulties would you expect? Because the entry point is going to be shifted posteriorly,
and
as well as laterally. So
I think I'll go for CCK in this case.
CCK.
Yeah,
would that be enough? CCK?
Yeah, hope it be enough. I need just the stem, intramedullary, and it will be fine.
وائل سمير فين؟ دكتور وائل.
Can you balance the ligaments with this degree of deformity, severe valgus sphere flexion deformity, and your entry point and your precise placement will be irrelevant to the anatomy of the ligament area. I think it will be difficult to use CCK.
That's right, rotating hinge.
So there are some precautions that, of course, you should have a C-arm intraoperatively to make sure that if you are going to collect it as one stage. And you should modify the entry point of the intramedullary rod according to the exit of the anatomical axis of the proximal fragment. And we have stems, offsets, augments to be ready. So this is the entry point based on the anatomical axis of the proximal fragment. And in the sagittal plane, it is a rather posterior entry point. And this is how it ended up. And it's now 12 years or 10 years down the line, and alhamdulillah, yeah, it passed, and the patient is still satisfied, alhamdulillah.
Assalamu alaikum, Dr. Ahmed. It's a very interesting case, but I think the choice of RHK in such cases would save you from many troubles intraoperatively. The entry point to the femoral canal has been shifted posteriorly and laterally, and I think the choice of RHK was a perfect choice. Thank you very much.
Thank you very much.